Following a blunt trauma to the abdomen, the patient is having a renal laceration. The urine has slipped out and that led to the formation of a urinoma. Now the question is, even after 12 days, the urinoma persisted, but the patient was stable, no fever. What do you want to do next? To manage those urinomas, you pass a J-shaped urinary stent, which is considered to be the management of choice. So this is the normal kidney, the other kidney would suffer laceration. Because of that, there is a development of the urinoma. And to manage this urinoma, you will be passing the J stent is what you need to remember. So what are the various non-obstructive causes leading to the development of the urinoma? So any external trauma to the kidney, urinary collecting system, pelvic, gynecological, retroperitoneal or a genitourinary surgery, any of them can predispose to the formation of the urinoma is what need to be remembered. Ravi is asking a very reasonable question. Why it is J-shaped, sir, but not S-shaped or C-shaped? Good question. Then urinomas can even be caused by obstructive causes like pregnancy, urinary like congenital anomalies, post-urethral valves, etc., etc. So you will be passing a percutaneous catheter and ureteroscopy, stone removal, stent placement, and there will be a resolution of the urinoma within about 1 week after you place the J-shaped stent is what you have to be doubly sure about. This is a very, very important question, doctor. A large number of you, 167 watching, I am very happy to see. Some of you are going to become MS General Surgery, MCH, Urology. Day in and day out, kidney stone is your bread and butter. Like an ENT surgeon, tonsillectomy is bread and butter. For an ophthalmologist, cataract, glaucoma are bread and butter along with refractive errors. For everybody, there will be half a dozen procedures which become our bread and butter. Unfortunately, to become a master in those half a dozen procedures, we study 5.5 years medical school, 3 years of post-graduation, another 3 years of sub-specialization. 11 years, like Ram went for Vanvas. That 5-6 procedures. Cardiologists, day in and day out, what do? Put the stent, take the stent. Put the stent, not taking the stent, put the stent, right? Put the stent, 2D echo, put the stent, 2D echo, which may VT, VF, AF, AR, valvular heart disease. That's the only thing. So ultimately, we read all this useless talk, SPM, PSM, microbiology, that organism, this organism. Ultimately, what we practice when you reach the top of a DM or a MCH, will be hardly 5-6 things to do, right? So that's the reason, go with a easy heart. It's nothing to do with your knowledge, your skill, your future as a great doctor, nothing. Entrance is nothing. Entrance is a quiz. Entrance is a game. Entrance is a filter. It is a test of your perseverance. That's the only thing you remember whenever you do wrong, questions wrong, MCQs wrong, whenever you get a very big rank unexpected. Don't take it too bad that you are something bad. You are already good. You are exceptionally good. That's the reason you already passed a filter and became medical students. So doctor, what do you want to do with this renal stone? So please don't forget, the various options available for you is depends on the size. You assess the size of this stone. Less than 1 centimeter, what do you want to do? Shock wave lithotripsy. More than 2 centimeter, you want to do percutaneous nephrolithotomy. If it is a 1 to 2 centimeters, then you assess the stone composition. Is it a cystine stone, bruchite? What is that? Then you have the option of either ureteroscopy or percutaneous nephrolithotomy. Suppose it is not a cystine stone or a bruchide stone, then you need to do the you need to look where is the stone located. If it is towards the lower pole of the kidney, then you need to do ureteroscopy or percutaneous nephrolithostomy. But if it is in the renal pelvis or the upper pole or mid-calyceal, then you need to do shockwave lithotripsy or ureteroscopy. So when will you do percutaneous nephrolithotomy? If it is more towards the lower pole of the kidney is what you need to remember. So the size criteria, site criteria on what is the treatment of choice for the stone disease is one of the favorite questions. I am betting you once more a question based on this algorithm will come in the tomorrow's AIIMS exam, and you are going to remember me while answering that question correctly, right? Now, what are the characteristic findings? Actually, there was another question of tumor lysis syndrome. So everything is hyper, uricemia, kalemia, phosphatemia, but calcemia is hypo, is what you have to basically remember. A 53-year-old patient was admitted with dyspnea. He has got a puffy face, engorged veins, SVC obstruction is suspected. X-ray shows mediastinal enlargement. What is the next best step you want to do? Obviously, you have to confirm what is the extent of compression by that mediastinal tumor. Tell me, doctor, what are the 4 T's? T, you remember when it comes to the mediastinal tumor is my question to all of you. T for teratoma, anteromediastinal tumors. T for teratoma. T for thymoma. T for retrosternal thyroid. T for terrible lymphoma. The 4 T's of the anteromediastinal tumor you should not basically forget. So this is the typical chest X-ray. There is a superior mediastinal widening and development of pleural effusion. And these are the typical right mediastinal nodes causing superior vena cava obstruction. Whenever the patient comes to you with this, the biggest challenge is it terrible lymphoma or is it a thymoma or a teratoma is a big challenge to know. If it is a lymphoma with the SVC obstruction, what is the good news? Lymphomas melt like ice when you happen to use steroids is what you have to basically remember. So there is a reason whenever you get a patient, you are suspecting lymphoma. In fact, you should err on the side of thinking that that SVC obstruction is because of the lymphoma. Administer him steroid. Steroids melt lymphoma like the ice snow is what you have to basically remember. Now, doc, how do you measure the nasogastric tube length which is required is a very, very important question. Beautiful question. Riles tube. How much Riles tube you require to pass? How do you measure? It is from the tip of the nose to ear to xiphisternum. Tip of the nose to the ear to the xiphisternum. You will basically calculate, and in this case of the child, it is totally 12 inches, 30 centimeters. Each inch is 2.5 centimeters, right? So 30 centimeters. So this is what you have to be doubly sure about. Now, doc, which layer, is the voice clear, is involved in the blister formation in case of the superficial partial thickness burn is the AIIMS November 2017 question. It is a papillary dermis. So how do you identify superficial partial thickness burns? They don't go deeper than papillary dermis. There's a blistering, loss of epidermis, underlying dermis is pink and moist, and the capillary return is clearly visible when blanched, and there is no fixed capillary staining. Pinprick sensation is normal, and they heal without scarring within about 2 weeks is what you have to basically remember.